Unfortunately, it's about 10 to 15% of women who are cycling have PCOS. 75% of them, I think, are undiagnosed. Once you start menstruating, it's very important to have normal menstrual cycles. If your cycles are not regular, that's a red flag that something is going on. 2002, when the Women's Health Initiative came out, that was a big study. They kind of scared women and their doctors about hormone replacement therapy. Since that time, 23 years, an entire generation of doctors who were educated during that time didn't learn about hormone replacement. That study did a huge disservice to women. It's probably one of the biggest sort of medical blunders that has happened in the last 100 years. Instead of going through their data and going kind of through the peer review process, they essentially went directly to the media and said, these hormones are dangerous. And then, essentially it became this like mass hysteria situation. And it has left a whole generation, many, many women without proper medical care. Unfortunately, less than 5% of women over the age of 50 who are candidates for hormones are currently taking them, which is crazy.
Hey, everybody. I am so excited for today's episode of the Gut Check podcast. I am sitting down with an incredible doctor, Amy B. Killen, to talk about hormone therapy and hormone optimization, how it impacts longevity. We're going to talk about the gut and hormone connection, the estrobolome, polycystic ovarian syndrome, what men need to look out with hormones, and so much more. So tune in and check out Amy B. Killen. Dr. Amy, thank you so much for joining us on the Gut Check podcast. I've been a huge fan of your work, and thank you for everything that you're doing, sharing about women's health, hormone health, longevity, so much more we'll dive into. But to start, if you don't mind, just tell us a little bit more about your background and your practice and the companies that you've started, all the amazing work that you're doing.
Well, thank you. So I'm Dr. Amy Killen. I am a former emergency physician. I left ER medicine in 2013. And so for the last 12 years have been focused on preventative medicine. I also do regenerative medicine, stem cell medicine, and a lot of hormones and a lot of women's health. I have a couple of different companies. I have a clinical longevity company that's called Humanot Health that has clinics in Austin and Florida. I also have a women's supplement company called Hotbox, and I have a couple of other smaller ventures in the regenerative medicine space. And I also see patients here in Utah, which is where I live currently. But super excited about women's health and women's longevity and hormonal health as well.
That's awesome. And so you spent how long? Was it about a decade in emergency medicine?
Yeah, I was 10 years in emergency medicine. And towards the end of that, I had my 3 kids within 2 years.
Wow.
And my husband left for an out of state job when my third one was a week old. And I had to be at work at 4 in the morning to go to my shift. And so I was getting up at 3 in the morning and basically did that for a little while and started to kind of fall apart and realized that if I didn't start making some pretty serious changes in my own life, I was going to be a patient in the ER, waiting to get seen for some kind of chronic medical problem. So that was 2013. That was kind of my aha moment, and realized I needed to learn how to be healthy. And so I left the ER, and that's what I've been trying to do ever since.
It's crazy. I mean, it's a super common story now of a lot of doctors. And I know, on our medical advisory board, a lot of our friends that were physicians and then made that kind of transition to more functional medicine, essentially.
Yeah.
What was that like? I mean, was there any tension there? Or was it just a kind of a healing journey all together?
It was a lot. I left the ER. I had this job, which I'd been training for a decade and went to school for.
Yeah.
And I had my identity kind of wrapped around being an ER doctor. And there wasn't a path at that time. Like at that time, there really wasn't a clear path to doing what I do now. Like I really
Yeah.
had to just kind of jump off a cliff and hope that I figured out something. And so it was a lot of just doing things that I wasn't sure if were going to work, and starting
Yeah.
clinics that I wasn't sure what I was doing, and
Yeah.
learning about business when I had no idea. So many years of kind of floundering until I started kind of getting myself grounded and was able to really work on this in a real way.
Thinking about kind of women's hormone health through different life stages, right? Because it starts with childhood, what they're eating, what is on them, whether it's like sunscreen products or all these different potential endocrine disruptors. So it starts day one, right? It starts before that, and then you have the puberty years, and all throughout fertility, and then of course perimenopause, menopause, and post. So I know that's a big question, but maybe just, how you think about hormone health and some of the non-negotiables throughout these different life stages that we go through as women.
Wow, that's a big question. It's so funny because until the last 12 years, I didn't even ever think about it. I
Yeah.
never even heard of most of these hormones throughout my whole medical education.
That's
But
and
now
that's
I'm pretty focused
crazy.
on them.
So in
It is
medical
crazy. It is
school, in
crazy.
medical
Like I
school,
had
you
never heard the word estradiol, I don't think, or progesterone
that's
throughout
crazy.
all of my medical education. But I think that it's the foundational stuff is always foundational. So whether you're 5 years old or 10 years old or 30 or 40, making sure you're eating as healthy as you can, as clean as you can, you're getting exercise, you're sleeping well, like all of these things, keeping stress down, all of those things can make a big difference in hormonal health and the way that your body's making hormones. I'm not a pediatrician, so I don't know a lot about early years, but I will say that, once you start menstruating, it's very important to have normal menstrual cycles, like to have regular cycles. And so one thing that I would tell women, if your cycles are not regular, if they're very chaotic, if you're skipping months, things like that, that's a red flag that something is going on. Unless you're on birth control or something like that. And so one of my first tips is, if you don't have regular cycles, go see your doctor and try to understand what's happening, because it's something in your body is yelling and saying, hey, we need some help. And I think we've gotten really good as a society of just kind of ignoring that and maybe throwing birth control at you and going forward, but we need to do a better job at that.
What are some of the main symptoms? What are some of the things that you would say outside of just cycle regularity that are the absolute like telltales that you've got something going on?
I mean, I think that there are a lot of symptoms. I think this the biggest thing is, if you think something is wrong, like something doesn't feel right within your body, then that should be taken seriously, and you should continue. You should have a doctor who takes that seriously. So maybe
Yeah.
it's you're gaining weight for no reason. Maybe it's you're
Mhm.
really fatigued. Maybe you're not sleeping well. Maybe it's, it could be skin rashes. It could be 100 different things. But if something doesn't feel right to you, then you should be empowered enough to go to your doctor and say, something's not right, help me
Mhm.
out, and then have a partner there with your
Mhm.
doctor to kind of start going deeper, because it could be any of dozens or hundreds of things, but your doctor is there to hopefully help you figure it out.
A lot of lack of education, I think, is a fair way to say it around hormone health in general. Why do you think that is?
Yeah, in 2002, when the Women's Health Initiative came out, that was the big study,
Yeah.
that kind of scared women and their doctors about hormone replacement therapy. And so basically, since that time, 23 years, an entire generation of doctors who were educated during that time didn't learn about hormone replacement, because they thought it was dangerous, so they just didn't learn about it. And so you have all these doctors who are now, my age or maybe even younger, who just weren't ever taught. And it's a big, to understand how to replace these hormones properly does take quite a bit of education, but it has to all be self-driven. They have to go to courses, they have to, go to
Yeah.
conferences, they have to do these things, because it wasn't taught in school. So it's a big hurdle, I think, to get over. And unfortunately, less than 5% of women over the age of 50, who are candidates for hormones, are currently taking them, which is
Wow.
crazy.
Wow. Do you think that's because the Women's Health Initiative and that study and just kind of the lack of good information or misinformation, however you want to say it, but I'll just say the lack of good information out there?
Yeah, I think the WHI, that study, did a huge disservice to women. It's probably one of the biggest sort of medical blunders that has happened in the last 100 years. And it has left a whole generation, many, many women without proper medical care and without, things that could have not only helped with quality of life. These hormones are helpful for symptoms, but even more importantly, these hormones are helpful for preventing chronic diseases like osteoporosis and heart disease and dementia and things that kill women. And unfortunately, there are a bunch of women who just never had access to them, and doctors who don't know how to prescribe them.
This one was super interesting to me because this was the largest clinical study, right, known to man. I think it was 160,000 women. Is this right, Dr. Amy? And then it was
I don't remember the exact number, but yeah, many, like more than 100,000 women.
but it was a $1 billion of taxpayer money, right? So, I mean, this
Yeah.
was a huge study, and maybe just shed some light into it in your opinion of what you think happened here.
So the study was, only about 2 years into the study. What happened was they were doing kind of preliminary data, looking at preliminary data, and they found that they thought that the women who were taking hormones had a increased risk of breast cancer, heart disease, strokes, blood clots. And interestingly enough, what they did was instead of going through their data and going kind of through the peer review process and publishing their data, they essentially went directly to the media and they called all the news stations and said these hormones are dangerous. And then essentially it became this like mass hysteria situation. Later, when they actually published the data and had the peer review process and everyone looked at it, we realized that it was only the synthetic progestin group. So the group that was getting this synthetic form of progesterone, it was only those women who had increased breast cancer. For instance, estrogen actually decreased breast cancer risk. And it was only essentially a small population of women who were having problems. This study also used kind of the wrong hormones. It used synthetic hormones, not bioidentical. And it also treated older women. So these women were 15 years out from menopause onset. So they were very, a lot older than most women in studies. So they did a lot of things wrong, but probably the biggest thing was just releasing their incomplete study results in such a way that caused mass hysteria. And unfortunately, once women are afraid and doctors are afraid, we know now, I mean, it's 23 years later, people are still afraid, even though this has been kind of debunked hundreds of times.
Yeah, and I mean, Marty McCary's point in his book, which, and someone can go look up and read, but on this study particularly is what happens, unfortunately, sometimes when obviously a lot of money is spent and it's kind of like a do not fail type of study and setup. So here we are, a lot of women probably could be on something that's more helpful, but you were saying it's only 5% of women are taking hormone replacement therapy.
Yeah, less than 5. It's like 4.2 or something.
And
It's
is
it's
that even the
absurd.
right word? Hormone? Because I know there's menopause. Let's break this down. There's menopause
Yeah.
therapy, hormone replacement therapy. I mean, what is the right way to communicate this? Because it is confusing.
This is an ongoing discussion. So the official name is menopause hormone therapy, but they're basically, and I don't tend to use that as much, although I do sometimes. The official name is MHT. That's for treating women in menopause. Um, HRT is the older name. A lot of doctors still use that. I sometimes do, but there's a lot of discussion because like I use these hormones, not just in menopause, and I also don't just use estrogen and progesterone. I'm also using testosterone and thyroid and melatonin and like other hormones. So I tend to say hormone optimization therapy, but honestly, there is no consensus about the best way except this MHT is the sort of standard way that the medical societies say.
I think the hormone optimization is a lot better. You're onto something there.
Yeah, I like
That
it, and
will
it's and I
capture
can say
more.
then I can say I'm a hot doctor, which is kind of fun.
That 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 will
HOT, hot.
that will capture the next generation better. Just having the word optimize.
I think so
and
too, and I also I treat men too, and that I treat men with hormones. And so
I,
being able to be a little bit more broad optimization and not just treating this very narrow
yeah.
menopause women group.
That's awesome segue. That was one of my other questions. So we talk about, it's women mostly talking about all of our hormone issues and everything, which is great. And that's, I think, a very positive step forward based on even what happened a couple of generations ago. But for men, what are you seeing right now? And what, even just, if you are listening and you're a concerned wife or spouse, what are some of the things that men should be looking for and how are you treating men?
So for men, it's low testosterone is the main hormone that we worry about in men. Certainly, men also have estrogen, but low testosterone. It's we know that testosterone levels have gone down over the last 50 years as a population for men. That they've gone down quite a bit, and this is probably a combination of just being less healthy. Not exercising, not lifting heavy things, not sleeping as well, more stress, plus endocrine disruptors in the environment. So you have all of these things kind of coming together as the perfect storm that is resulting in men's testosterone trending down. And testosterone is really important for both men and women, but in men we know that lower testosterone levels are highly associated with higher mortality rates, with higher heart disease rates, with higher problems with brain cognition, et cetera. So and testosterone is used to make estrogen. So if you don't have enough testosterone, you also don't have enough estrogen for men. So usually we're replacing testosterone or we're giving medications to help your body to make more testosterone. one thing that's great about testosterone is it does respond well to lifestyle changes. So for men who are younger, especially, their testes still work. If we make changes to lifestyle, oftentimes they can make their own testosterone, with some effort, which is a little different than women. In menopause, once you lose, estrogen, progesterone, it's not a lifestyle thing. It's just your ovaries are not functioning kind of thing.
So if you saw a male that had low testosterone and was, let's say, 36, it's like young enough, what would you say are the first things, just the first handful of lifestyle interventions that he should make?
So the first things are lift heavy weights,
Mhm.
get a little sun so you have some vitamin D. Make sure you're sleeping well, 7 or 8 hours a
Mhm.
night, ideally. Reduce stress. High stress is a cause of low testosterone for sure. If possible, reduce some belly fat and
Yeah.
visceral fat, which will also help. And then make sure you're getting some of the micronutrients like vitamin D, selenium, some magnesium, some of those things to make the testosterone.
All of these little choices, obviously food is such a fundamental aspect of it as well, but all these little choices that are adding up into what, you say it perfectly, which is this perfect storm. And so I always say it's not productive to get stressed about our stress levels, and it's not productive to get overwhelmed. It's really just, okay, what are the two or three things? And even if it's just one, just change one thing a week. And before
Yeah.
you know it, I mean, that's really, especially when it comes to hormone health, I think what makes the biggest difference.
Yeah, absolutely. I think that it feels very overwhelming if you try to think about all the things that are like coming at us, that the microplastics and the endocrine disruptors and the xenoestrogens, and that, like, it's stressful. And I totally agree. I think that stress is not going to be helpful. And the best thing to do is try to really approach it from I can do what I can do, like consistency, moving towards better every day, but understanding that it's a pretty big task to be perfect, and most of us aren't.
Yeah, and I mean, even just one thing that I always say for men and for women is sleep. If that's like the
Yes.
first thing, because if you're not sleeping, then all of these other changes are going to feel way too overwhelming. Everything is going to
100%.
feel.
After I had my kids, I went back to, after I had twins, after I had them, I went back to the gym I think I was like 2 months out from having them. I had a C-section. I was like, I need to go to the gym. And I hired this personal trainer who I just met at Gold's Gym. And I was going like twice a week to the gym. And I was like, I was going to lose weight and all this. After a couple of weeks, she looked at me and she goes, Amy, are you sleeping? You need to be sleeping. And I was like, well, I'm sleeping like 2 or 3 hours, but like I don't have, I have twins and they're always up. And she looked at me and she said, if you don't get sleep, then nothing that you do here at the gym is going to make a difference.
Yeah.
You need to use this time to sleep and come back and see me in a few months when you have enough sleep. And then we'll work on your exercise and all of those things. And I thought that was so smart because she was
Yeah.
completely right.
No, it's when our body detoxes. It's when our body replenishes itself, and again, just from a mental health, all of kind of the overwhelm and the anxiety of all these other things. If you are missing your periods or have low testosterone or having fertility issues, unfortunately, that's a lot of our friends these days, right? That are trying to
Yeah.
have children, and all of that, can't even begin to be solved without sleep. So, and I wanted to kind of segue a little bit into, we've got, which I think is great, a lot of information now, a lot of entrepreneurs, doctors, business owners on social media talking about testing, talking about, okay, if you have this symptom, you need to get tested. And I think that the testing can be incredibly confusing. If you can kind of clarify for especially young women who might just be kind of a little bit overwhelmed and then getting tested and confused by the results, when is testing necessary and how should we think through those results?
If you are young and you have normal cycles and don't have like specific symptoms that are concerning around the cycle, then you can I don't necessarily think that everyone needs to have like estradiol and progesterone checked at their yearly visit, like unless you are having specific symptoms. Certainly thyroid should be checked every year. Certainly your insulin, your metabolic disease markers, things like that should be checked, I think, at least every year, if not more, at your regular visit. If you're looking at estradiol or progesterone, you do have to decide what you're trying to figure out. Like if you're trying to look at whether your progesterone is high enough, then you want to check it at around day 21 of your cycle, which is when you're going to see the peak of your progesterone. If you're looking at whether maybe you're starting to have symptoms of or early kind of premature ovarian insufficiency, your ovaries are not starting to work right, then checking earlier in the month and looking at estrogen and FSH is important, like day 2 to 5. So you need to have a doctor. You don't have to know this. You need to have a doctor who understands your cycle enough and what they're looking for to be able to dictate when to do those tests. But for the most part, unless you're checking those two specific hormones, you don't have to do it at any time. It can be any time of the cycle to check testosterone and to check, all your other metabolic markers.
This is the other very common issue right now is that women will go into their doctors and I said, a lot of times it's who insurance is covering for them or the doctor that they've got. They'll say, hey, and they're being informed by, frankly, a lot of times it's Instagram or TikTok, right? But they're being informed and they're doing some research. They're coming to their doctor saying, I want these labs. And it's just this uphill battle. What would you say to young women like that? Is it essentially you're going to have to go find a functional doctor, someone like yourself, and just get out of the system? What do you normally say to someone who's having issues with more of the conventional OBGYNs and
I
doctors?
mean, I think it again depends on what your actual concerns are, what your issues are. Like if you're having many traditional doctors are great at looking at, can be good at thyroid disease, for instance, or prediabetes or some of those things they should be equipped to handle or at least identify. But if it is something that you're really wanting to dive deeper than a functional medicine doctor or an integrative medicine doctor, someone who maybe can get tests during different times of the cycle, maybe they're doing other kinds of tests, maybe they're doing gut microbiome tests or micronutrient tests or urine metabolite tests. Like as you know, there are hundreds probably at this point
Yeah.
of additional tests that can be done. I don't think everyone needs most of those tests,
Yeah.
but you need to have a physician or provider who understands which of those tests would benefit you and which are just going to be more noise than helpful.
So with your work specifically, someone comes in, you're doing testing, right? So you're guiding them through this, and then you're essentially recommending, and this is a really important aspect of your work too, is bioidentical hormones, right? Versus, I think the right way to say it is synthetic. Is that the right way to differentiate? I mean, how do we
Yeah, I mean, I think I don't like the terminology, but yes, that is kind
yeah.
of the accepted terminology.
And what is the difference between the two for someone who just doesn't know?
So bioidentical just means that the chemical structure of the hormone matches that of the chemical structure of the hormone that your body makes. So my body, your body, our bodies, the primary hormone that we make for primary estrogen is called estradiol. So ideally, when you're taking hormones later, perimenopause, menopause, you're taking estradiol. So they look the exact same, they act the exact same in your body. The alternative to bioidentical are what are kind of called synthetic hormones, which again, not the best name, but that's just what they're called. And that's basically anything that is not bioidentical. So it looks a little bit like estradiol, but it has an extra group attached to it. So it still binds the same receptor, but maybe not in the exact same way. So like in the Women's Health Initiative, which you talked about, they used a synthetic estrogen called Premarin, which actually came from pregnant horses' urine. That's where it was derived from. That was the estrogen they used. And that was kind of problematic. But the real problem was the synthetic progestin, which is kind of like progesterone, but like a zombie version of it, right? That was the one that really caused the problems in that study. So most doctors at this point who are doing hormone replacement therapy are using that bioidentical form of hormones, but there are some doctors who still are using the old synthetic versions. And I'm surprised every day when I see those. Unless
Yeah.
there's a good reason,
Yeah.
I don't reach for those first.
Why, if there were bioidentical hormones used for these therapies, why wouldn't they have used those, especially with a study as large as the Women's Health Initiative?
Yeah, I think it probably comes down to who's funding the study. The synthetic versions of these hormones are all drugs. They're all pharmaceutical products, and so we do have pharmaceutical product versions of bioidentical hormones. By the way, you can get those at a regular pharmacy. You don't have to go to a compounding pharmacy, um, but yeah, I think that they also thought that they were going to work. I mean, I think that they were
Yeah.
comfortable at that time. This is what they were hoping would work. And we've learned a lot since then. We've
Yeah.
learned why that wasn't a great idea. I think that that's fine to be wrong, but we just need to know that there are other options out there and we have them and they're not expensive in general. So I think there shouldn't be a good reason now that doctors are not prescribing estradiol and progesterone, which are those bioidentical versions.
What are the core ages that you're prescribing these bioidentical hormones for?
It is wider. I certainly do prescribe them, both of those in menopause, and those are the kind of, estrogen, progesterone, both. I also prescribe a lot of progesterone, especially in perimenopause. And perimenopause is the 2 to 10 years before menopause. It can start as early as 35 and still be considered normal. It can start earlier if you're premature menopause. But low progesterone is a very common problem in perimenopause. So oftentimes I'll prescribe that then. But then I also use progesterone for things like women who have PCOS. If you have irregular cycles with PCOS, progesterone it's a mandatory addition to PCOS because you can have high amounts of estrogen, you're not making progesterone, and that high estrogen over time can be really problematic for increasing risk of breast cancer and things like that. So I use it also in women who have like PMS. If you have a lot of pain before your cycles or heavy cycles or migraines before cycles, any of like PMS symptoms, adding a little dab of progesterone during the second half of your cycle can make a huge difference. It's so easy and it's so safe.
First of all, just for someone who has never heard of PCOS, what is it? And how often are you seeing it in your work?
So PCOS is polycystic ovarian syndrome, kind of a bad name, kind of a misnomer if you ask me, because it's essentially it's implying that everyone who has this syndrome has multiple cysts on their ovaries, which is actually not true. Not everyone has cysts on their ovaries, but really what it is it's an endocrine disease that is usually you have a insulin resistance, so you're kind of trending towards diabetes, and you often also have a high androgens, so high levels of testosterone or other androgens like precursors to that, like DHEA. So it's those two things. It's the high insulin and high androgens that are the trouble causers, and then you got to get a whole bunch of other things that may happen. You may have irregular cycles, you may not. You may have infertility, you may not. You may have ovarian cysts, you may not. So it's a lot of like vague things. And unfortunately, there's no single one test that we can do that says you have this versus you don't. It's kind of like a compilation of symptoms and tests that come
Mhm.
together. But unfortunately, it's about 10 to 15% of women who are cycling have PCOS.
Yeah.
And 75% of them, I think, ish, are undiagnosed.
Right. So a lot of women have PCOS and just don't know it. And that's what's going
Very
on.
common. Yes.
How do you identify it when you are meeting with the patient? And then I want to try and get into like what are some of the things that women can do?
So, I mean, some of the symptoms that may go along with it, irregular cycles, like I said,
Mhm.
that's one you should always have a workup for that.
Mhm.
If something like high androgen symptoms, like if you're having extra hair growth on your face or you're
Mhm.
losing hair on your scalp, or things like that can sometimes be seen with PCOS,
Mhm.
not always. But if you're having those kinds of symptoms, infertility, you've been trying to have pregnancy, or you're having early loss of pregnancy, like in first trimester, is
Mhm.
often seen with PCOS as well. But some women don't have a lot of symptoms. The testing usually will start out with just simple blood tests. We'll do blood tests, then look at your some hormone levels. You look at your testosterone, your DHEA, your DHT. These are all androgens.
Yeah.
Also look at your insulin and your blood sugar and see
Mhm.
if you have evidence of insulin resistance, which is oftentimes seen with that. You can also look at your AMH, which is another blood test that
Mhm.
looks at your essentially how your brain is speaking to your ovaries.
Right.
And so there's some tests like that, FSH, LH, some blood tests that we can look at. And then you can also kind of go further. You can do like an ultrasound of the liver. Oftentimes these
Mhm.
women will have a fatty liver on their
Mhm.
ultrasound without even knowing that they had that. So you kind of put all those pieces together and then can usually get a diagnosis.
So there's an overlap between PCOS and diabetes, correct?
Yes.
And
Yeah.
so is it possible that a woman's going into her doctor with all these symptoms and they're being mistreated, right? For something like diabetes where they might have PCOS or vice versa. I mean, how do you see that those two things correlate?
Yeah, I mean, a lot of PCOS, a lot of women will have some insulin resistance, meaning they either have prediabetes, some will have diabetes.
Mm.
There is quite a bit of overlap. The treatment for the insulin resistance piece is it's going to be helpful whether they're kind of just purely pre-diabetic or they also have PCOS. So, like, oftentimes it's certainly lifestyle, certainly working on
Mhm.
low glycemic foods and getting enough protein and exercise and stress management, all the things we talked about. But then also will oftentimes add a medication or supplements like berberine or dihydroberberine can be great for this,
Mhm.
or like the GLP-1 medications
Mhm.
like Ozempic, Wegovy. Those are actually great for PCOS, or some other drugs called the SGLT2. So there's some drug categories that can be helpful whether you have
Yeah.
PCOS or just insulin resistance, but always the foundational stuff with lifestyle and maybe some supplements too.
So when you're seeing someone, either if they've got PCOS, they're younger, or they're going through hormone replacement therapy, hormone optimization therapy for menopause, perimenopause, are you also addressing lifestyle? And what are some of the things that are, again, kind of the foundational non-negotiables with lifestyle, just particularly focusing on women's hormone health?
For women, especially as we get older, the resistance training, weight training becomes even more important. Like, starting at like 30, 35, I really want you to be focusing on muscle building and bone health, because by 35, your bones are as strong as they're going to be, and it just gets worse. So you really want that peak to be high. So lots of jumping exercises, sprinting, high intensity kind of interval stuff that like gives your bones impact is important. Weight training is important. Then everything else, the sleep, the diet, all of those things continue to be important no matter what age you are.
Thankfully, I do think that's a good trend that's happening with women right now, is not necessarily, competing in bodybuilding, but it's really focused on just like great muscle building. And I think that's kind of a more and more I'm seeing, at least for my peer group, 30s, I'm starting to see more and more women get into that, which I'm like, that's awesome.
You need to be doing weight training at least 3 days a week, and it should be like heavy weights. Like, it's not like
Yeah.
these little baby barbells and you're
Yeah.
you're you're doing like Jane Fonda
Yeah.
exercises. This should be like this: you're grunting and you're sweating and you don't look pretty.
Yeah.
Like, that's the kind of weight training you want to be doing.
So I wanted to segue a little bit talking about the gut and hormone connection. And something that we've been taking a close look at is what's called the estrobolome. So would love to hear your thoughts, your opinions on how the gut is connected to our hormone health and to specifically estrogen metabolism, detox, etc.
Yeah, I mean, the hormone, estrogen, the gut estrogen connection is so fascinating. They both influence each other, right? They certainly, as you estrogen changes, as you get into perimenopause and menopause, it has bad effects on the microbes of your gut, so they tend to kind of become worse microbes. But also, especially during your perimenopause, premenopause years, the health of your gut directly influences the type of estrogen, how much estrogen you have in your body. So to kind of go a little bit deeper, you have this kind of compilation of bacteria that they call the estrobolome, as we talked about earlier. And these bacteria have a direct effect on how well your body is able to either recycle estrogen or kind of keep estrogen out of your body. After estrogen has gone in your body makes it. It gets thrown out into your intestines, and it has this kind of extra chunky piece on it. And there are some bacteria that have the ability to remove that piece. They're called beta glucuronidase yielding bacteria. And essentially, when they do that, the estrogen can get reabsorbed. And this may not be a good thing. It may be a bad thing, especially if it's done too much. So essentially, these bacteria can decide kind of how much estrogen is getting reabsorbed back into your body. And if there's an imbalance in those bacteria, maybe you're absorbing too much back in your body, or sometimes not enough back into your body.
One of my favorite parts of our work is just the complexity of the gut microbiome and all these things that we're learning. But it's a very wise system.
Yeah, it's so fascinating. I mean, certainly in your gut, these microbes are there. They're also in your vagina. So
Yeah.
as you go through perimenopause and menopause, you lose estrogen. That also affects the microbes in your vagina, and
Yes.
it's a shift, kind of the bad guys. And that's why we see so many increased infections in women
Yes.
after the age of 50.
Yep.
You're getting more yeast infections, bacterial infections.
Yep.
Like, all of this comes down to the microbiome. And these are all in your skin. Like, these
Yep.
microbes are everywhere, of course. And estrogen, it strongly influences all these different microbes. So it's a fascinating, like, as you said, like, it's super complicated. I certainly don't know everything about it, but I love learning all the things that we are learning about the microbiome.
There's a lot of stuff that we do know now, which is great. But most of this we don't know yet. And that's the way that at least we approach our work every day, is very exploratory. The things that we know that can be helpful, awesome. Let's get them out to people. Let's get that to the market. But then there's so much of this that just has yet to be discovered. So
Well,
it's,
and I think also the way they all interact is that what
yes,
we also really have, we're just starting to be able to use AI and, these
yes,
big data sets, because, you've got so many different things coming. You have your genetics and how your genes
yep,
are, looking at things. You have your microbiome, you have your hormones, you have your function of various organs. There's so many different pieces of the puzzle, and they all affect each other. And, until recently, we haven't been able to take all of this data and combine it together to make really personalized, health decisions or observations. And I think that that's a big thing, it's starting to happen, But in the next 5 years or so, we really will be able to take these large data sets, put them together and say, you know what? All of your information tells us we should do this for you, which is not the same as somebody else.
There's no supplement protocol that anyone should be on for their entire life. I mean, it just doesn't
Yeah.
make sense, right? I mean, there's different things that you need. So I'd love to hear your perspective of that. How, obviously we talked about lifestyle interventions, which is the most important part, just to be very clear. I mean, there's
Yeah.
no way to supplement your way out of lifestyle interventions. You can't supplement your way out of sleep or diet or anything. But again, they're great tools and they can be really helpful. So I'd love to hear your perspective. Obviously, you have multiple companies, you're in the supplement industry and in the space. How do you approach supplements? How do you think about them? How do you recommend that your patients use them? All of that.
Yeah, so I actually started several years ago a supplement company called Hopbox,
Mhm.
HOP Box, and I just to essentially create a like daily pack for women with the things that I think that are most often not easy to get in food. Like, assuming that your diet is good, that you're doing all the things you should. Like, what are the things that maybe aren't in food or aren't in high enough doses in food that women often need, kind of in midlife, like 35 to 50 or so. And there's some things in there that we talked about, like dihydroberberine, which is similar to berberine, really good for blood sugar, also lipids, inflammation, things like that. But also just the things like vitamin D and vitamin K and magnesium. Some of these micronutrients that many people are low in. Magnesium is a big one. But kind of putting those things together. But my overall thought on supplements is, they are not necessary necessarily for everyone, but I do think that they can be helpful for specific things. And but understanding what your goals are and having a physician or practitioner to work with you and make sure that I don't think you need 100 pills a day. Like, that seems absurd to me. Like, I feel like you should be able to do it in 10, 5, like something
Yeah.
more reasonable. And then everything else should just be lifestyle.
The vast majority of consumers don't want to take, 100 pills a day. And even I know the prenatal that I'm taking is like 8 a day, and that's a lot. And most people could not do that. I mean, it's just too much.
Yeah, it's a lot. And I think, people get pill fatigue, and we also don't know how they all work together. Again, like, unless you've actually studied the combination you're taking, like we're doing a study with Hotbox right now, and looking at some of those metabolomics, epigenetics and things. But unless you've studied that actual combination, you don't know what those pills that you're just throwing in there all together are doing. You have no idea.
When it comes to, mothering, just let's talk about young girls first. What are some of the things that you look out for when it comes to hormone health?
So I have twin daughters who are 17 right now, and my son is
Good.
15. So this is,
Right.
right in that time
Yep.
where I do think that, that advice is important. I've talked to them a lot, and they don't always want to talk to me. So, they're always they kind of close their ears, but I still talk, and I hope that I absorb some of it. But I've talked to them about, hormones. I think, making sure, again, cycles are regular, and that, I think if you're having any severe symptoms, like any severe PMS symptoms or heavy bleeding or migraines before your, migraines every month, or, debilitating symptoms, like, that is not normal. Like, it is not something that should be normal. It is not optimal. It's not okay. And that should be something that should be discussed with your doctor, and then they hopefully will actually address it. I've also talked to them about birth control, and when you need it, like, what are the options. I was on birth control for like 15 years myself, like just the pills. I had no idea that there was maybe a better way potentially.
Yeah.
So I like to have the discussions about what birth control is kind of like. To me, it's like a kind of a hostile takeover of your body. Like, it's
Yeah.
these synthetic hormones at very high doses that you're
Yeah.
taking in, and certainly it has a purpose, and I'm
Yeah.
glad that we have access to birth control pills, but also it's a hostile takeover. It's taking over the way that your brain communicates with your ovaries.
Mhm.
It's taking over a lot of your own pathways, and I think that there's a time and a place for it. But I also think that we could probably not give birth control quite as often in that way, if people knew kind of the increased risk of blood clots and potentially breast cancer down the line and things like that. So just thinking through the positives and negatives of some of those kinds of things. Certainly the lifestyle piece continues to be important, but at where my kids are, it's more about like, how can we safely get you through like your 20s,
Yeah.
and those kinds of years where there's some tough decisions to be made.
What are some of the things that you're still the most concerned about, whether it be kind of fertility rates or these issues, diet, lifestyle? What are some of the things that you're most concerned about over the next decade? And then what are some of the things that you're most optimistic about?
I am probably the most concerned about just climate and environmental problems, environmental toxins, environmental, issues, climate change, whatever your political views on this, we
Yeah.
know that things are going in a worse direction.
Mhm.
And I think that if we don't have clean air and clean water and clean soil, then virtually like nothing else really matters that much.
Yep.
And that, we as humans continue to pollute around us and
Yeah.
are not really being supported in that. So that's my biggest concern, honestly. Fertility rates going down does concern me for
Yep.
sure. I think that is something that is a direct reflection of lifestyle and
Yep.
the climate and
Yep.
the toxins in the environment. So that worries me as well. I'm optimistic about just the learnings that we're getting from all of this data. I do think
Yeah.
that we're going to make some strides in terms of improving personalized medicine, improving, being able to help on a one-on-one kind of basis. I'm
Yeah.
hopeful and a little concerned about how we're going to get that information to the masses, to all the people around the planet, many of whom can't afford to go to a
Yeah.
functional health doctor and pay out of pocket and get all these tests done. So I think that that's something I'm hoping we can kind of figure out, but I don't see a clear path to that right now.
Yeah, great responses. Yeah, I equally concerned about the environmental toxins. I think that, even just in our products, but water, it's like one of the most simple things right now. We're living in one of the wealthiest nations in the world, and I'm still, concerned every day about filtered water and just what's in the water. I mean, if that's here, I mean, that's pretty bad. And so,
Yeah.
these
Yeah.
these things are causing infertility. They're causing, there's this direct implication, and it's a really tricky one because it's not one thing, it's so many. But our food system, right? I mean, our food system isn't great. What do you do about diet personally, and then diet and holistic hormone health? How can women change their diet to really support their hormone health?
I think the some of the biggest pieces of diet that are important for hormones for my kind of midlife women, and I tend to treat women who are like 35 plus,
Yeah.
but it's probably applicable to all women. Getting enough protein is
Yep.
really important. Getting enough fiber is really important. Fiber should be 25 to 30 grams per day.
Yeah.
Most people in the US get like 10.
Yeah.
And I have to admit, I'm not always the best at it, but I do try.
Yeah.
And protein, there's a lot of arguments on how much protein people need. And, there's people on both sides, but,
Yeah.
somewhere in the like 1.6 to 1.8 grams of protein per kilogram is
Yeah.
probably about right. But again, there's a lot of debate. But you shouldn't be getting 20 grams a day or 30
That's
grams a
right.
day. It should be more
Yeah.
like 100 grams a day kind of
Yeah.
thing. And then I also think having enough like good fats in your diet is really important. Omega 3s, omega 6s, whether you supplement, whether you eat fatty fishes and things like that that's important for many aspects of cell function and cellular membranes and things like that. So I think if you kind of focus on getting enough protein, getting enough fiber, and getting some good healthy fats, then you probably are not going to be overeating other things. You're probably not going to be eating too many Twinkies and such if you're getting that much protein and that much fiber every day. So that's usually where I start.
That's a great response. What's your a take or your opinion on fasting for women?
Fasting, I think it has purposes. I'm not as big a fan of fasting as some people
Yeah.
because I don't hate it, but I
Yeah.
think that not everyone needs to be doing it, I guess. We know that fasting doesn't necessarily cause weight loss unless you're reducing your overall calories. The fasting itself is not going to help you lose weight generally.
Yeah.
For women, especially, again, kind of thinking about my population and myself, I don't want you to lose any muscle as you get older. And I do worry, like if I fast, then I will lose muscle because
Yeah.
I'm already pretty skinny and I have a hard time building muscle. So for me, I like to eat and make
Yeah.
sure I'm getting those kind of spaced out. I think that, if you, there's a lot of people who like to do 18-hour fasts and 16-hour eating or, 18-6, those kind of fasts are perfectly healthy and I think probably have some value. But I'm not as excited about fasting as I think some doctors are.
Yeah, that's a great response. Likewise, I think that especially with younger women, it's kind of thought of, oftentimes this is premenopause, but how do I, use fasting to lose weight? And it becomes a little bit sometimes like a crutch, like a crash diet that
Yeah.
ultimately will jack up your hormones if you're not having protein first thing in the morning. Well, thank you so much, Dr. Amy. Where can we find your work? If someone's interested in working with you directly, how can they find you? And any other announcements that you have from your businesses?
So I'm very active on social media, especially Instagram. Dr. Amy B. Killen is my full handle. So find me there. I'm also very active on Substack. I put
Awesome.
articles out usually twice a week and put a lot of time work into those. So I'm on Substack. Same thing, Dr. Amy B. Killen. My website is dramykillen.com, and that kind of has links to all of my clinics and my different companies, supplement company, Hotbox, things like that are all on my website. So check that
Awesome.
out. And yeah, I mean, I have clinics now in Texas, Florida, and Utah.
Wow.
So if you're in one of those states and want to be a patient, probably not of me personally, because I'm not taking new patients, but the clinics are, and I'm
Yep.
overseeing all the providers at all those clinics as well. So
Awesome. Well, thank you. I so appreciate your time. I know that this conversation is going to be super helpful to so many people. So I appreciate it, and we'll talk to you soon.